So yeah, hello everyone. Welcome to this third edition of our radiation treatment planning workshops for physicists and dosimetrists all over the world. It's an absolute pleasure to have you. The first workshop we did was treatment planning, but kind of anatomical site agnostic. Then the second workshop we held was in last February was in breast treatment planning. And today we will be talking about the details of pelvic planning, so both prostate and gynecological malignancies. So there's a few housekeeping things. Please remain muted when other people are talking. Also, if you have questions during the talks, write them in the chat, and we'll get them at the end of the lecture. And there'll be time at the end for question and answering, and at that time you can unmute yourself and ask the question physically. But if it's during an actual lecture, just type it into the chat, and we'll get to it when the Q&A session comes. You guys will all be given a certificate, at least those that have attended. So I believe someone will be keeping track of that, and probably Alicia, and will send you the certificate in the coming days. And yeah, so otherwise, please enjoy and please ask questions. Try to engage with our speakers. They possess a wealth of expertise. For many years and many different sites, but today we'll be focusing on pelvic planning. So without further ado, I will introduce our first speaker. So that is Allison McCarthy. So she's the chief dosimetrist at NYU Langone. She graduated from the State University of New York's at Stony Brook with a Bachelor of Science in Health Science. She completed post-bac medical dosimetry certificate program at Stony Brook University School of Health and Technology and Management, obtaining her MDCB certification in 2005. In addition to administrative duties, she is involved in clinical work, education, and research at NYU. She's part of the QA, QI, and DEI programs within the department. She also serves as the preceptor of medical residents physics rotation and a member of the medical physics residency steering committee. And as someone who went through a medical physics residency myself at some point in my life, I definitely appreciate the dosimetrists that put in time to the physics education. So Allison, thank you for coming here, and I'll turn it over to you.
Hello, everyone. I'm just going to share my screen. Today, okay, is everyone able to see it? Yeah. So today I'm going to be covering the 3D portion of pelvis GYN planning. So just a little background for GYN cancers, the most common in order are endometrial, ovarian, cervical, vulvar, and vagina. And there's different types of treatments, but the most common to do a radiation therapy would be brachytherapy or external beam radiation therapy. The external beam radiation therapy can be delivered either with 3D conformal or IMRT. There's also surgery and chemotherapy as well, but we're going to be concentrating on radiation today. So when the patient comes into the department, they receive a simulation. There's two different, the most common two positioning for GYN or pelvic cancers in general are supine and prone. For supine in our department, we position the patient with a vac lock and we give them triangulation marks around the pelvic. The vac lock tries to help with day-to-day reproducibility. The second is prone. Depending if the department has the equipment, you could use a prone pelvis board. The advantage of the prone pelvis board would be dependent on the patient's mobility and what positions they're able to tolerate for a period of time needed to treat the patient. But if the patient's on a prone belly board, this allows the bowel to fall out of the field, and it could reduce toxicity to the bowel depending on the patient anatomy. If the patient has mobility issues or is not able to hold that position, the patient might also be treated supine, which you could use the field arrangement and blocking to try to avoid the bowel in that situation. So when you get into 3D planning, there's two predominant methods, which is a 3-field beam arrangement and a 4-field. The 3-field beam arrangement would use a PA field, a right lateral, and a left lateral. This is advantageous if possible if the PTV or the target volume does not extend as anterior to the patient's surface. If you could get rid of the AP field, again, you might be able to spare some bowel because you'll have less dose coming through the bowel that's not in your targeted region. If the target volume comes to the skin or it is a little bit of a bigger patient, you might need to use a 4-field approach. So that would still use the PA, the right lateral and the left lateral, but it'll also have an additional AP field. And you could adjust the weighting of the AP field as well as the other fields to get the best plan possible. So the treatment fields for GYN cancer vary dependent on site. Today, I'm going to concentrate mostly on cervical cancer just due to limitation of time. For cervical cancer, the superior border is usually around L4, L5 interspace. The inferior border is at the bottom of the arbitrator forum. The lateral is 1 to 2 cm lateral of the pelvic inlet. Anterior is encompassing the pubic symphysis, and posterior, they split the sacrum. Sorry, let me get this out of the way. Endometrial, the superior border is a little bit different. It's at L5, S1 interspace to include the common iliac nodes. Inferior, it's the bottom of the arbitrator to include the common iliac nodes as well. Lateral is a minimum of 1 cm lateral to the pelvic brim to encompass the external and internal iliac nodes. And anterior, it encompasses the symphysis pubis. And posterior, it splits the rectum, sacrum. These are the default field arrangements, field borders. But if there is like a node or if there's any gross tumor volume, you probably will include that into the field, and it might make these fields not be exactly as said. So here's an example of an AP treatment field with the bladder, rectum, and femoral heads turned on. Here's an example of a PA treatment field with the same structures. Left lateral and right lateral. So for 3D planning, there's two predominant methods to use. You can use wedges or field and field. Wedges, depending on the equipment you have at your institution, might be physical wedges, which get placed in the gantry head during treatment. Dynamic wedges use MLCs that move during treatment to produce the same wedge angle as a physical wedge would have done. It just eliminates the need to put the physical wedge in the machine, which most machines are moving towards. There's also field and field. So field and field allows you to block out certain hotspots to get a more conformal, less hot plan. And this could be done manual technique where the planner adjusts the MLCs or the field, I guess, draws if there's not MLCs to get the best plan, or a vendor supplied software such as RAD-Formation's Easy Fluence. Today, I'm just going to go through demos of wedges using dynamic wedges and field using the manual approach. So when you use wedges, just as a little overview, wedges could do two things. They can make up for a missing beam or missing tissue. And this is examples with the physical wedges. With the physical wedges, you're a little bit more limited. You have to choose the direction of the wedge, and it's the same for the whole field. Field and field, as we'll see, lets you kind of have more versatility with blocking out the hot spots or getting a more conformal plan. So for the missing beam, that's saying that this is 3 fields. So you have 2 laterals and a PA. The beam that's missing is the AP. So you're going to put wedges on the lateral sides to make up for the dose not coming here. For this plan, if you didn't have wedges, you would see a hot spot over here because it's being treated by more beams than the anterior portion. So the wedge allows you to, with the fat end where the hot spot is, push more dose anterior just to get it a little bit more conformal over the treatment area. Missing tissue is a patient's anatomy, and you'll see that most patients aren't a square box. So if you're coming in without any wedges, you'll see that your depth and tissue distance is a lot greater superiorly in this example than inferiorly. So in this case, you would use a wedge with the fat end inferior to kind of make up for this missing tissue. So it's going to block more dose from the inferior to allow more of a equal distribution from this field. So I'm going to go through the demo for those cases. So the first one we'll do is the wedge. So when you're doing a wedge, if you're doing a physical or a dynamic wedge, you need to ensure that the collimator is in the right direction that you want the wedge angle to come in from. So in this case, as we just discussed, we would want the wedge to be in the posterior aspect on both the lateral fields. Sorry, all my buttons are blocked. So I'll show you what it would look like if there's no wedges in this plan. So you see how there's a hot spot posteriorly in the patient because more dose is coming in to this region. So you would want to add some wedges to account for this. So the wedge is going to be on the Y1 axis. And a usual to start with, I would do a 30-degree wedge on both of the fields. So as you see now, the heels are placed posteriorly, and then we'll recalculate the plan. So you see how the hot spot moved a little bit more. It distributed anterior to posterior a little bit more, but you'll notice over here that the wedge, we could probably use a soup to inf wedge as well, just because the patient's tissue is missing. Which my field size doesn't allow for at this point. Sorry about that. And when I was saying before how you have it's a little bit more versatile using field and field. Wedges don't always ideally be able to compensate for the plan. So if you were to use a fat wedge here, yes, it'll push the dose up here, but you'll see down here we're missing dose. So it's the soup to inf wedge doesn't always help because you're going to then make this hotter and this cooler. So unfortunately, field and field for this case would be more ideal, but just to go through with the group, one thing that we want to see when we're doing GYN planning is we want to weight the plan as much through the laterals as we can, but we don't want too much hot spots on the outside. At our institution, our rule of thumb is to keep the 90% out of the entrance and exit dose that's out of the target. So once you calculate the plan, in order to see whether or not the wedge that you picked is ideal, you would look and say, right now you'll see this plan is over wedged, that it's blocking a little bit more here and making it hotter here. So then you would go and reduce the wedge. And calculate the plan again. So you see it's a little bit equal a distribution, and then you could also play with the weighting in order to get the most ideal plan. So in this case, if we would turn on our hotspot of 115, we'll see it's on the superior. So I'm going to raise the posterior a little bit more. That's it. And when you're reviewing the plan, it's best to scroll up and down through the plan just to see your distribution on each slices, not just one slice. So since I increased the posterior, I'm going to increase the wedge as well. Sometimes with wedge plans, it's a little bit going back and forth between your wedge angle and your weighting. For the safety of time, I'm just going to do a few iterations, but it's something that you would just need to play with to adjust to get the best weighting for each of the plan, each of the fields, and the wedge combination. Something to mention that I forgot to mention before, energies for the plans is dependent on the patient anatomy and the location of the tumor. If you're treating a patient which has a little bit of a bigger anatomy, you might be okay using 15 for each of the fields like we did here. If you're treating a patient that is pretty skinny, or if there's a node or something that's superficial, you might need to kind of change to 6x or 10x or a lower energy. Let me check where we are with time. Okay. So I'm just going to jump to the field and field because I think that might take a little bit more time. And I think that's, we could come back to the for field if needed. So first thing we'll do is the same, we'll calculate the plan. So I chose, you could also use field and field for a 3 field. I chose it just to do 1 3 field and 1 4 field. So right now, once we calculate the plan, there should be an op structure. For field and field, unlike the wedge plans, I don't like normalizing to a point because if you block that point, it might kind of throw off all your normalization. So how I do it, what I find is an easy way is do a quick calc of your fields and then convert your 90% isodose line to a contour. And then go into contouring, and we're going to subtract this for itself. And this is just a rough estimate of the field size if you don't have a PTA. So you could crop it from itself. So we would say crop the structure we just created, remove extending outside, and then we'll choose it itself as well. And I start off with a 7mm. Then you hit apply, and you'll see it's cropped within itself 7mm. And then just as a sanity check, I would go back to external beam and look at each of the beam's eye view and just ensure that that structure does not stick out of any of the beams. It might need to be edited. So here's the right lat, so that's good. Here is the AP. Right here is the left lat and the PA. So comes out a little bit, but it should be fine just for using for optimization. I find that's a good rule of thumb, but you're free to normalize to a point if you prefer it. So you would select that op structure as your target. And we'll start off with something as 195. So in order to do the field and field planning, first we want to kind of just make sure that our weighting is about where we want it to be. So we want to see the hot spots equally distributed. We want to, again, see at our institution, we try to keep the 90% outside of outside in the entrance and exit tissue. And you also want to try to limit the dose if you're using a 4 field coming through the AP field. If there's portions of the AP field that do not, if there's portions of the bowel that's not in your target field. So if your kind of field would end here, you see how the bowel's in the field no matter what. So you might want to do more of an equal distribution. You might want to do more of an equal distribution just because if you weight it less anterior, you're not going to be sparing any bowel because there's no bowel outside of the target region. But in this case, you'll see that the anterior field, the anterior portion, as we get more superior, does have bowel that's outside of the target region. So we would reduce that AP field and accept a little bit less conformality, not too much, but just to limit the dose, because we don't really, if you see here, you're 70% laterally. We don't really want the 70% to be extended into the bowel that's outside of the field. We prefer that it would go into the soft tissue where there's not that many sensitive OARs. So after you play with the weighting, for this case, you see how it's equally weighted here, but we're still able to spare the bowel somewhat with the 50% anterior. We start the field and field. An easy way that I like doing the field and field is finding my hotspot, which in this case is 113, and turning off all my other isodose lines in the 3D view, as well as the structures. And changing this to a little bit of a higher hotspot of like 111. And then I would start little by little with each of the fields trying to block out that hotspot. So you'll see in this situation, this is where field and field is more advantageous than using classic physical or dynamic wedges. So the first thing you would do is you would create a field and field, and you would block out on the new field the region of that high dose. And I think with field and field, it's always best to do not too drastic changes on each iteration because it might have a negative effect on the plan. So first I'll just start with the AP and PA field. And for each of these, I will do a field and a little subfield. And then we'll calculate it. Just wanted to get that up. So while that calculates, Eclipse has a nice little nifty function where it does give you the field weights, where if you change one, it will change the distribution of the other. So, and I think this is where it comes in handy to have that optimization structure, because you know every time you recalculate, your PTV is still being covered by the same dose. If you were normalizing to a point, every time you recalculate these field and fields, it doesn't necessarily mean that your PTV is still getting the same amount of coverage. So you won't be comparing apples to apples with respect to the hotspot. Good. And then I'll just do one more on each of the AP and PA to now block out a smaller region to try to eliminate that. And just for the sake, the issue with time, but you could be a little bit more precise when you're putting on the field and fields to block out those hot spots, and it'll help. And then we'll do the PA. And then you would keep on going through these iterations. Once your hotspot gets down, like 111, then I would try to target a smaller isodose level and maybe try to get it from different volumes, different fields as well. So, and again, here's a great example of how field and field is a little bit more versatile, because if you were trying to block this out with a wedge, you would not be able to, because the hot spot's not just posterior or anterior or superior or inferior. So this is where field and field actually makes the planning a lot easier. So we'll try to block it out. And we're going to just close the MLCs in certain portions. A lot easier. And again, if you had a little bit more time than we have here, you might be able to spend a little more time being precise with the field. So we'll go from here. And then also the left lateral, new field and field. And calculate. Okay, so a hotspot. We don't want to just look at the beam's eye view. You also want to go back to the actual plan and just make sure that nothing crazy has happened. Again, if you were normalizing to a point without realizing, you might be given the PTV maybe 70% of dose, not 100. So just keep on looking at the plan. And then it's kind of a back and forth between adjusting the isodose line. And with most planning, you could kind of go down a rabbit hole of, you could put as many field and field as you want, but you kind of got to balance it with what's clinically going to be significant. And also, how much time do you have to spend on a plan for that thing? So if you look here, if we go, we're still keeping the 90% out of the soft tissue. But if you look superiorly, we're able, again, to still keep the 50% off. And my hotspot's 109. So it depends kind of what you're looking at in the plan and what the institution or MD's like. We like to keep the hotspot, if possible, below 108. And again, depending on patient's anatomy, it might not also always be possible. So in order to reduce it in this one, we probably want to look at the weighting. So for this case, we could take back our field weighting tool. And we might want to reduce the amount coming from the PA. So an Eclipse has this field weighting that I find is very helpful with field and field. So you could just lock your PA and increase the weighting slightly on the rest of the fields. and then go back one more time to your field and fields and see if you could maybe block it out to reduce it even more. What I like doing between each iteration of adding more field and fields is make sure you save, because sometimes when you put on a field and field, again, it might do something drastic, and you kind of want to be able just to reload and go back to the one before it. So looking now at this, to see where I'm going to do the next field and field, I'm going to do it from the PA field and kind of just block out what's hot that hasn't been blocked yet. So new field and field. Down here. And here. And then I'm going to give it the weighting and calculate it again. Good. You see how it's, so it got rid of the 108 mostly, but maybe if we increase this a smidge more. Okay, so now we're slightly below 108. So we're going to go back again and look at our axial slices just to make sure that we we're getting the coverage that we want, and also turn on our OARs at this point. So scrolling through it, the coverage, our hot spots where we would like it, the dose outside the field, treatment region is in over 90%, which is what we go by, and the entire field is covered by either the 100 or 90%, and you might also want to look at it in your sagittal view as well. So we see the 95% covering here, 100 everywhere else. If you would like your 100% to cover superiorly, you could adjust your fields and fields even more. But at this point, and due to the time constraint, because I think we're running out of time, I think this is an acceptable plan to be used for a 3D pelvis. And then depending on your institution, you might want to merge the fields. I know some institutions don't merge the fields, so that's dependent on your institution and whether or not you perform any quality assurance before or log files during treatment is institution specific as well. So I'm going to stop there at this point because I think we have five minutes left just for any questions.
The one question that came in the chat was, is it possible, or do you ever use three field and field technique?
Yeah, so we use wedges. Well, we moved away from wedges, but if you're using wedges, you could use wedges for 3 or 4 fields. And if you're using field and field, you could use it for 3 and 4 fields. I just picked that combination. So I was able to show a 3 field, a 4 field, and then also I was able to show field and field and wedges. So you can mix and match to whatever you want. It's more, let me see what my screen is. 3 versus 4 field is more dependent on patient anatomy. So ideally, you want to spare the bowel as much as you can. So you would remove that 4th AP field whenever possible. Sometimes this plan, when it was clinically planned, was a 3 field. I created it as a 4 field just to kind of show the group. Sometimes if the patient's very big, or again, if for some reason there's some gross disease that might be anterior or more superficial, you may need to use that 4th field. And then with respect to wedge and field, especially for pelvic cases, I do think field is more optimal because as you saw, you don't always get a hot spot in a direction that a wedge could help, right? Because our hot spot when we first calculated it was pretty much here. So a wedge kind of we wouldn't be able to ideally use a wedge to even out the dose for this missing tissue because it was in the middle. Good question.
Can
I
I
have a
also
quick
make a
question.
comment? This is Alicia.
Go on.
Um,
Sure.
Sure.
and similar in those types of situations, I've even mixed wedges and field, like put wedges on the lateral and make the AP or PA beam a field.
Yeah.
So you can also do that.
I have a very quick question, because as you said, right, it's like going down a rabbit hole. You can keep doing these fields. For a given field, how many fields do you find yourself in your practice usually stopping at?
So for the most part, we have a default. We could only do 6 fields in total per gantry angle, so 5 subfields in an open field. And then also, sorry, something I forgot to mention is our institution has a minimum MU of 4. So some of these fields, like we would have to increase it in order to use it. It's be dependent on the institution, but the more field you do, you don't want MUs that are not really going to be doing anything to the plan. So while you can with less than 4 MUs, that's just something my institution uses. But you also want to make sure that your machine's able to, if your machine's able to deliver the plan you gave. So technically, and if you look at some of those planning challenges that get done, I'm sure you could create a plan that has 20 subfields, whether or not it's something that the physicists might have a heart attack to, or it's also going to take up time at the machine. And depending whether or not you merge your fields, it also opens the door to, like, before we merged our fields into one field, we had to image each subfield. So there's limitations about like the practicality of using a lot of subfields. But I think for pelvis, something along this lines, I think 3 to 4 per field would probably be kind of what we would get in the end if we had the time to do it here per field.
Right, and yeah, for the physics perspective, those on the line, the reason why we don't want to use such low MUs is just because at very low MUs, the output is quite unstable. So when you're using segments with 2 MUs or something like that, you're adding significant uncertainty into the actual dose that the patient is getting. A few more questions came in online. What's the purpose of the 90% isodose line you converted to the structure?
So when you're doing field, if every time I recalced it, you don't want to normalize to a point and then put in a field that blocks out that point and it throws off your whole distribution. Whereas if you're still normalizing, say, to this calc point, you might get a lower hotspot, but if you're not realizing, you might also reduce coverage along your PTV. The 90% is something, if you have a PTV, then you normalize to the PTV. I know sometimes when we do 3 fields or 4 field pelvis, we don't normally have a PTV per se because it's more by anatomical guidelines. So then once you create that 90%, it's just something to give you a structure to normalize to when you don't have a PTV. Same way with breast planning, you convert, in that case, since it's just plain opposed fields, to 50%. This is just something that I find it's easier after you calculate, if you're keeping the set normalization on the same structure, you're knowing that your field is reducing the dose, reducing the hotspot, but still keeping the same coverage. If you were normalizing to a point, you may reduce the hotspot, but you may be reducing your coverage significantly as well. So you don't have
Yeah,
to use that 90% cropped in within himself. You could use the calc point, but just make sure you keep going back and forth and making sure that the PTV wasn't coverage wasn't hindered too much.
and one final question for you, Allison.
Mhm.
Right. If you didn't have MLCs, do you think you would still use a four-field technique? Maybe just comment on how that would kind of change the way you approach the problem if you don't have MLCs.
So without MLCs, I think 4-field would probably be more conformal than a 3-field, just because again, you don't have that missing beam on the top. But if you don't have MLCs, you could still do field and field. It's a little bit tricky, and you can't merge the fields, but for some reason, just you needed to do it. I'm not sure you have to do it. But if you had a hot spot, let me try to. If I had a hot spot, it was really hot here for some reason, maybe due to the patient's anatomy. They might be a little bit bigger in the hips than they are on the top. So just say your distribution had 110 here and and only had 100 here. You technically can do field and field by just truncating your jaw. So one of your field and fields may look like this. And again, that's might not make your physicist happy, but if for some reason due to patient's anatomy or they were previously treated or something where you really need to get a conformal plan, without MLCs, you can achieve it with either wedges or doing and just truncating some of the fields. If you were going to go with that approach of just changing the draw, I would not suggest more than one field and field per beam, just because that would be a little bit more of a drastic change.
And real quick, one last question came in, maybe in 1 minute answer. What dose do you aim for the femur?
The femur, since it's not IMRT, someone will be covered IMRT later. I think you would have to accept at least 104%, 105%. In this case, it's probably like 103 because your femur, if you're talking about the femoral head, is in the field and you can't carve it out. So if you're expecting your field to get 100, I think you need to give like 3 to 5% with 3D as a is just to, like you see here, it's 103. We wouldn't want the hotspot on the field if avoidable, and that's kind of why you see hotspots more in these 4 corners. You want to try to avoid the hotspot in the field, but it's not always possible. And if your institution would like it to be less than that, I think they would have to accept maybe 95% coverage there. Because I think in general with 3D, you do need a range of like 3 to 5% across the board.
Thank you so much, Allison, for your presentation and then the resulting discussion after. It was very much appreciated. I'm sure people on the line appreciated it as well.
All right, and thanks for joining, everyone. Let me stop sharing.
Yep. So we're going to transition now to IMRT GYN. So for this, we have the pleasure of having Kim Martyr on the line. So Kim is a senior medical dosimetrist at University of Maryland Medical Center in Baltimore. She received her MDBC certification in 1990 and holds 2 master's degrees from the University of Maryland. Her leadership background includes the director of radiation oncology. Currently, she plays an active role in departmental research, co-authors numerous publications, and is a member of several AAMD committees. Along with her role as HDR program lead, she teaches dosimetry students and has spoken at several AAMD national conventions. She currently acts as an AAMD mentor to a rising dosimetry student aspiring to enter the field of dosimetry, and her goal is to leave a legacy of compassion, hard work, and commitment to the future dosimetrists of the field. So yeah, without further ado, I hand the mic over to Kim to discuss IMRT and VMAT planning of GYN.
Good morning, good afternoon, good evening to those who are on. Thank you for letting me take this time to show you a little bit of GYN VMAT, what I call tricks and tips. Just go to, oops, I'm sorry. Just want to see my, okay, this is my home away from home. I'm at the University of Maryland in Baltimore, and I don't have anything to disclose. So today we're just going to go over some of the objectives of what exactly VMAT is, and discussing the rationale. We'll look at the targets and OARs that are applicable to creating a VMAT plan. Also kind of talk a little bit about the role of the bladder, and how it affects the bladder fill, how it affects planning. I'm going to just show you some little tips that I use to help sculpt the dose, some of the arcs that I choose, of course, the clinical goals, and how we utilize objectives and constraints to meet those, and then how we analyze the plan. And then I will touch very briefly on the physics, QA, and verification. That is not what I do as a dosimetrist, but I want to make sure my plan is verifiable and friendly for the physicist. So we all know that VMAT stands for volumetric modulated arc therapy, and it is used. Allison did a great depiction of 3D, and it is kind of the reverse, where we are trying to achieve a goal, and so we're working inversely to do that. So where she took all that time creating those fields, we are asking the planning system to create those for us. You want to consider the number of arcs. You don't want to have too many because you want to reduce the table time and the throughput, especially in very busy clinics. You want to know what the target dose coverage is. What does the attending want you to achieve as far as target coverage? But along with that, the organs at risk and what your sparing percentage constraints are. So like I said, it's inverse planning. You're going to start with a desired outcome, and you're going to work backwards with the planning system creating beam intensities, using the MLCs to inherently create those fields that Allison was just showing you. You always need a dosimetrist involved with this. I always tell this to my students, because one thing is just choosing the pertinent gantry angle and collimator angle will help to minimize the organs at risk and maximize the target coverage. So we're talking about bladder fill. In our department, we will usually scan these patients both with a full and an empty bladder, and we will fuse those and let the radiation oncologist decide in each scenario which is the better image set to actually create our plan. You can see here I have one with a full bladder and one with an empty. And what that does is it creates more separation between some of the organs at risk, especially the bowel. So for us, we usually do our GYN cases supine. We have done some prone, but we find, and it could just be a region, but in our region, we have a lot of women with kind of large pannus, and sometimes the reproducibility with them being prone is problematic. So we do them supine, but we fill the bladder and empty the bladder and determine which is the better set to actually plan and receive treatment on. And then if it is a full bladder, that woman is instructed to drink a certain amount of water each day before treatment. We don't catheterize because that kind of reduces the throughput time and is not necessarily comfortable for the patient. So of course, the things that you must have to do a VMAT plan, actually for even a 3D, is you need to have some targets that are delineated by the attending. That would be your gross tumor volume, any nodal in volume, which we considered CTV or clinical target volume, and then a margin around all of this, which we call our planning PTV, which allows for any motion and setup variance. With the VMAT plans, we can actually use a much smaller PTV, and we can dose escalate. We also want to have some defined OARs that are pretty much standard across the system. We have 9 systems within our large institution, and we want to make sure that we are naming, our nomenclature is the same, and that our volumes are the same as far as what clinical structures that we are looking at. This is good for data mining, but it's also good for standardization, and it allows you to follow a lot of the various, whether it's ICRU, NCCN guidelines, the various clinical guidelines. For us, it's very helpful if you have outside imaging that we use to fuse. PET and MRI have really become our best friends. Sometimes also enhancing CTs with contrast. We generally will fuse those from outside. Patients been to their local imaging center, and then we fuse all of these in. It helps tremendously our attending as far as delineating the target and the clinical nodal volume. So you can see here, these are the different targets that we might get on average plan. You can see that this light blue is what they're calling our ITV vagina, and this is just where the gross disease is. But then we also have our nodal volume, which is in here in the yellow, and then we have about probably a 0.3 to 0.5 expansion, and that is what we're considering our planning PTV. We do a lot of SIB, which is simultaneous integrated boost, where we might be running this ITV to say 50.4, and then the nodes, which you see here, are superior to the ITV. We might run those to 45 or vice versa, just depending upon how the patient presents. And we do a tremendous amount of HDR, high dose radiation, to follow. So our brachytherapy follows. So we might want the nodes to only get a certain amount, or the ITV, and then follow it up with high dose radiation. These are our organs at risk. We usually use the standardized nomenclature. It follows some of the ICRU guidelines and also some of the RTOG guidelines. So it's very helpful when you're trying to do some data-driven results as far as outcomes for your institution and compare them to others. So we will have the left and right femoral heads that we stop at the trochanter. We will have the bladder. We will have the small bowel. We'll have the rectum, large bowel in many instances, and lately we've also been doing the sigmoid. We have residents, so we are always trying to include them in the OARs, but lately our dosimetry staff have been charged with contouring a lot of what we call the normal volumes, with the attending and resident doing a very good check on these after the fact. But you can see here why I was talking about the bladder fill, because whether it's empty or fill can really move the small bowel and the rectum, and also if we had sigmoid, can move those around significantly. So one planning tip that I like to use, I've used this for years, you want to sculpt as much of the dose as you can. So, with VMAT, you are going to put some objectives in to cover your PTV. At least 95% of it would get 95% of the dose. Some RTOGs want you to get 95% to cover 100% of the dose. But with VMAT, you have that low dose bath. And yes, it will greatly reduce the bowel and the bladder volumetric doses, but you want to just be mindful of that low dose bath. So I create what is called a ring. And this ring right here, I take my PTV, I expand it by 1.2 centimeters, and then I subtract that same PTV and expand it by 0.7. And this ring right here, when we get to the constraints, I'm going to set a constraint to kind of make a maximum of 70%. What that does is it really pushes in the high dose to make it very uniform and conformal, and starts to work on reducing some of this low dose bath outside. So remember in the 3D where you saw, remember Allison was saying they try to keep the 90% out. This actually reduces, you better not see 90%, and you shouldn't see much more than 50% out here, and then that low dose spread. As far as placing the isocenter, we use RayStation, and we just auto place the isocenter within the PTV. What this does is it helps the MLC, the carriage motion for the MLCs, so that it's somewhat symmetric. What it does also do, as you can see here when we set it, it's outside of the PTV. There's not a problem with that. This makes for the planning systems, it makes it easier for the optimizer to work and assign MLCs. But when you go to do the verification, physics will often say it didn't verify, you have a very large gamma, and that's because their QA system is looking at this point in relation to the targets. So what we will often do, we call it a DSP point or a physics point, is we will place it in a good piece of tissue, so that when we send it through we use Mobius, but when we send it through our QA verification, that the gamma would be within our 3 to 5% region. Generally, for us, with our through point and patient comfort, we will generally use 2 full arcs. This gives you enough real estate to meet the target coverage and reduce the organs at risk. And generally, you want to rotate the collimator 10 to 20 degrees off axis, off of your 0 axis, or in the case if you use off 90, this just helps the smear and the MLC carriage as it's rotating around. So I generally use a 191 to 181 with a 350 degree collimator rotation. And then I just oppose it with a 181 to 179 arc rotation with a 10 degree clockwise collimator. Then what I do is I actually, in our system and in all planning systems, you can leave it so that the jaws just automatically open to the PTV. But in this case, we use what is called a flip-flop technique. And what it does is it helps to allow for even more efficient leaf carriage motion in the X direction when you are rotating your collimator off of 0. So I will go in and I will set my jaw so that the outside of the X and Y jaws are half of what it would have been if it had just auto opened to my PTV. So generally I will have a 2 centimeter overlap, and I purposely do this because with VMAT, it will smear. So you don't have to worry about overlap. If you did this in 3D, that would be a mess. You would have a major hot spot right along this region here. But with VMAT, and you set your objectives, you have a slight overlap of the fields, as you can see here, and it will smear this out and make for a nice homogeneous conformal coverage of your PTV. And this just kind of helps us reduce some of the organs at risk. So I use a little bit of margin outside of my PTV, maybe 1 to 1.5 centimeter to open it. And then I have this 2 centimeter purposeful overlap. So in our departments, our prescriptions range from 45 gray and 25 fractions to 50.4 gray and 28. You'll see that especially if we're doing the 50.4, if we're doing the simultaneous integrated boost, but the whole pelvis will get 45, and then we might, like I showed you before, we might dose escalate that ITV to 50.4, and we generally follow all of ours with HDR. But we want to optimize it to the PTV average. So that is kind of how we set our prescription to let the planning system know what exactly is we want to achieve. With VMAT, you need to enter in the fact that your technique is going to be VMAT. You need to give the number of fractions, and you need to tell it, what is my target? What do I want to cover? and to the average or the mean of that. It's very important that you do that. The machine also needs to know the position of the patient, whether they're head first or feet first. And in this case, you can see where I chose the full bladder. And this is a discussion that we had with the attending, and they said, make sure that we plan on the full bladder. If you do that, I like to go back and I like to put DNU or do not use on the empty bladder. So there's absolutely no confusion going forward. Now, like I was saying, clinical guidelines are going to be your best friend. I remember someone asked, what do you use for your femoral head dose constraint? Data-driven guidelines are best, I feel, because then you have a good objective measure when you are running the plan, when your physicist is QAing the plan, when your attending is analyzing the plan. We have our own internal guidelines, but those are based off of RTOG, the ABS guidelines, ECOG. We're always partnering with other institutions. To me, it raises the bar. It keeps you relevant. It keeps you up to date with whatever the newest guidelines are. And it keeps your planning skills, to me, I think, superior, because now you are objectively measuring your outcomes to some national and international institutions. So that's a discussion that you can have with your institution as to what guidelines you'd like to follow. So this is just a sample of something that we use in our department. We actually have made templates, and they are specific to each disease site. And right now, we kind of have attendings that are assigned to different sites, but often, depending upon when a patient comes in for consult, another radiation oncologist might see that patient, and having the same clinical guidelines helps to keep everybody on task. I have also worked in institutions where Dr. A likes this and Dr. B likes this and Dr. C likes this. And there's nothing wrong with that if that's what your institution is driven by. But it's helpful if you create some clinical guideline templates. And that way, when you drop those, you don't have to think about it each time. You also don't run the risk of putting in the information incorrectly. So for example, if you want it at most the CTV 50.4 to get full prescription, that's different than at least. And the same with your OARs. You want to have limits, top limits, not at least. And I've seen our students do this all the time. And they're like, I've got green checks. Everything is great. You have to be very careful, because you are now leading your attending incorrectly into him thinking that you've met guidelines just because you've not entered them in properly. So for us, we like to achieve at least 99% of these volumes, these target volumes, getting the full prescription. We generally get about 99% overall. And then we have some guidelines for the small bowel, the bladder, femoral head, and the rectum. I always remind the attendings, and especially our residents, if you don't contour it, I can't tell you a dose. It's very important to contour anything that you want to be able to analyze. In the case where we're doing these almost peri-aortic kind of pelvic plans, the kidneys need to be included, because you can't forget that they might possibly get some low dose spread. So anything that you contour, you can then create a DVH and have some objectives to follow. These are some samples of what we set. This can be physics driven, but the number of iterations. So that means the number of times that the planning system will go through trying to create a deliverable plan using fluents to cover your target and spare your organs at risk. We also like to set a leaf motion constraint, and this means it's every centimeters per degree. So, when I do 179 to 181, that's a lot of MLCs, and they're reconfiguring every so often. And we want to constrain the leaf motion so that we have a desirable plan that is reproducible and can be verified by QA. This is what I was meaning about the gantry spacing. So every 2 degrees from 179 to 181, those MLCs reconfigure. So that would be like poor Allison every two degrees having to make another field and field and a field and field and a field and field and a field and field. But that's the beauty of the planning system, is it can do it for you based on your gantry spacing and what you have put in for your constraints. This again can be recommended by physics or by the, generally it's physics, because most of the planning system gurus will hedge on, talk to your physicist, because different institutions set different parameters for planning. So remember those objectives. These are very important because now you know what your goals are. So you need to set objectives so that you can reach these goals. You can do this by dose, by your clinical knowledge, by your EUD, which is the equivalent uniform dose. You just want to think about how you're going to assign these objectives to create the outcome that you want. So what I generally do, and this has always worked for me, is I first want to create just some optimization goals for just my targets. I want to see if the arcs that I've chosen and the collimator angles that I've chosen will indeed create this kind of coverage, that my CTV will get 50.4 uniformly, that the PTV, I shouldn't have too much more than 107%, but I usually put a max of 105. But we generally are fine, our attendings are fine with a 107, 108 hotspot as a point dose. That minimally, I don't want my PTV to receive less than 95% of the dose. I also put this goal in for my external because, like I said, VMAT throws a lot of low dose in, and you want to try to minimize that low dose bath as much as you can. So I will create a fall off from my 95% region to my 50% region. And I want to kind of reduce that. And then remember the ring that I created before? I want that ring to be a separator getting no more than 70% of the dose. So what I'm going to do first is I'm going to run this, just optimize it just for my target coverage. It tells me a lot of information. It might send me back to the drawing board and say, Kim, what kind of arc angles did you choose? What kind of collimation did you choose? It also tells me what's driving my plan. It's like I say soup, but now it's getting to be fall. If you make a pot of chili and you throw everything in at once and somebody says, oh, it's too spicy, what are you going to do? Because you put everything in at once. So I want to just run it for target coverage first, and then it will automatically show me how my OARs are going to look based on it being able to create that target. So this again was my fall off. These are just more sculpting tips that I use. And I was talking about that external. I know Eclipse has another way of doing a fall off, but for RayStation, you can just set some values to maximize your sculpting. I call it sculpting dose fall off. And then that ring, again, you want to put a 70% of your prescription on there. So you can see when I first ran it for coverage, this is what my OARs look like. So yeah, it covered it nicely, but am I happy with this? No. So now I can either set EUDs, I can set max volumes, I can put some points along my DVH curve, and as I run it, I'm gently wanting to move my OARs to my left and my targets to my right. And that's the goal. And I would always advise that you not just be reliant on your clinical goals and did you meet your objectives, but you want to look at this DVH, because yeah, you can look at the high dose, but there's things you can do that helps the patient with the low dose area. I don't have the bowel. Let me see if I put the bowel. I did not. But one thing I failed to turn on here was the bowel. And a lot of times you can't do too much with the high dose, but you can look at like your V20, your V25, keeping it less than 50% will cause the patient to have a little less nausea or squeamishness, or those are the things that sometimes make the patient call out for the day. And you want them to come Monday through Friday or whatever your treatment regime is, so that they can get the maximum benefit of the radiation. So looking at things that can reduce some of the lower dose in these organs at risk is just as important as trying to look at max or some of the higher dose. So I always say, be very familiar with your DVH and do use that as part of your analysis as you're running these plans. These planning systems work so quickly with your optimizations in your iterations. When I first started years ago, you run it and leave it overnight, and now you can run it in like the vendors say, 5 minutes with coffee, and you've got to. But it allows you to quickly analyze and continue to move these DVH lines. So you can see here, this is after running a plan with VMAT, using those 2 full arcs and setting some optimization to cover the target and to spare. But you can see this purple is your 50% line. So when you think about what that 4-field box looked like, where your 50% was way out here, your 70% and sometimes 90 can be in the femoral heads, you have a super conformal plan. Look at that 70% line, which is this cyan. That is from that ring recreated. And then you can see your 95 and 100 is very nicely covering your GTV or your clinical target. We always put our 105 on because we want to see where those are. And if indeed we need to reduce those, we don't want big islands of 105. And like I said, for us, we keep our maximum around 107, 108. But even from the sagittal, you can just see, look how much of the small bowel, large bowel, sigmoid you are reducing greatly. Look at your femoral heads and especially the femoral necks, where a lot of these women who have bone density issues can suffer from fracture anyhow. All of this kind of helps to give better quality of life for these patients. So the last thing that I like to do after I've run it for target coverage and then run it and continue to reduce my OAR spare is to renormalize. And I call this like my last little dash of salt or sprinkle. What this does is, if we go back here, sometimes this red 100% and the blue, especially the red, might be a little broken up. I like for my 100% to be contiguous. I like it to cover my GTV or whatever I'm calling my gross tumor volume. And so to do that, when you first run it and you've got everything like you want, to now make it so it's contiguous, I might just renormalize to like 99%. What that does is it boosts these numbers significantly. So it will now make my CTV 50.4. I have 98.6% getting my full prescription dose. My PTV, instead of 95% for 95, I have 97%. So it increases it, but do be mindful. Don't get carried away with the salt. We don't want high blood pressure here. We know that every time we increase by 1%, we are also increasing our OARs by that percent. So it's a fine line. It's a very fine negotiation where you just want to end up with a nice contiguous 100% covering that target volume. So after your plan has been created, you like it, you've met your goals, and then your attending has blessed it by looking at all of it, looking at the isodose coverage, looking at the DVH, and looking at the clinical goals. Then we send our plans electronically to our record and verify, and our physicists do a quality assurance. We want to make sure that this looks beautiful as my desk is back in the department or my desk is home remote, but will this actually be a good deliverable plan that is going to happen efficiently every single day for the patient? So it has to go through some sort of QA process, whether it's delivered on a phantom or you have some sort of electronic verification program. They want to check the MLC motion. They want to check the appropriation for each of these MLCs and how it's modulated. They want to check the gamma. there's numerous things that our physicists will check above my pay level, but I know from sending it just to Mobius, is the plan going to deliver? Are there some delivery issues? Maybe a arc collision possibility. All these things you want to check way before it gets to the machine for the therapist to hit that treat button. So it's very important that your institution has a good QA plan verification program to ensure that you are indeed getting the outcome that you want. So in conclusion, VMAT for GYN planning does give a very conformal dose coverage. It really enhances your OAR spare, reducing normal tissue. So that's just your good normal tissue tolerance. And you're able to dose escalate, especially in the events of SIB planning and providing the patient, putting them in a good position if they indeed need HDR to follow. It's really important that you have skilled clinicians. That means from your sim therapist and getting good bladder fill and good positioning and good immobilization to your attendings as far as following guidelines for contouring, the organs at risk and the targets, and also for your dosimetrists to be able to use these tools that we have appropriately. You want good physics support that QAs and blesses every single solitary plan. And then you want good therapists that can set these patients up in the same position and ensure that what you created at your desk is actually going to be delivered every day. It's good if you can have some diagnostic imaging for fusion capability with MR or PET. That helps your clinicians tremendously and really narrowing down the clinical target volumes. You want good planning systems that enable you to carry these out. I would venture to say all of the planning systems can do some sort of inverse planning, but you want to make sure you've had discussions with your clinical team and especially physics as far as some of the settings that you want for whether it is your degree per, how many degrees each time the MLCs will, modulate. You want to have all of those discussions up front. And then it's also very good if you have some sort of onboard imaging like KV or OBI, because our PTVs, as you can see, are much smaller as far as your expansions. So you're not really allowing for as much wiggle room as we did with the 4-field box, which is still perfectly fine because you are still including those targets within. But with VMAT, we're getting what I call a little cute as far as these target volumes and expansions are very small. And then to have a good peer review, our plans are peer reviewed by other physicians on a weekly basis for any of our new patients, so that we can indeed feel comfortable and feel that everything is appropriate before we move forward. So I'd really like to thank you for your time and attention. These are just some tips and tricks that I've come across, and myself and our colleagues were often sharing information of things that can help us to use these awesome tools that we have to allow for this awesome target dose escalation, but we do it with caution and commitment. And I thank you in all languages for your time and your attention.
Thank you so much, Kim. While you were talking, a number of questions have come in the chat, so
Oh
we'll
boy,
start
okay.
going through them. Do you guys use VMAT for hypofractionated treatment of cervical cancer? And if so, do you know what protocol they use to evaluate the plan?
We are doing we're moving to a lot of really short course, not so much for the cervical. I'm seeing it a lot in the breast, not so much in the cervical as of yet in our GYN. Like I said, our center is kind of the hub, and we do pretty much all of the HDR for all of our suburban and rural centers. So generally, we are still seeing like a 45 gray and 25 fraction course of as far as patients that we're even receiving from other institutions. And then we are doing the HDR to follow. So I'm not seeing that as much in our institution as I am with some of the other sites, site specific.
And some of the people on the line might be participating in this, but yeah, they're going to be running clinical trials on hypofractionated cervical cancer in an African setting. So a number of African hospitals are going to be running because GYN is such a burdensome cancer in Africa.
Interesting.
So how do you handle bladder filling? Do you scan once with an empty bladder, once with a filled bladder, and then fuse them, or
Yes, that's exactly what we do. We do comfortably full because if we choose full, we want the lady to come in comfortably full. We don't want them to be so uncomfortable that they end up having to, expel right when they get on the table. So we do comfortably, we'll do an empty first and a comfortably full. We fuse them, and then it's up to our attendings to choose which one they want to use and make sure that that communication is specific, and then I usually mark the image set that we're not going to use so there's no confusion.
right? Similar question. How do you deal with air or gas bubbles in or near the PTV?
We generally, for the most part, don't acknowledge that as much. I mean, we do the low residue diets and stuff, clear stuff for the HDR, but for the external beam for the VMAT daily, we don't really seem to have too much trouble with that. I know that I can remember back in the day when they used to use the rectal tubes to try to expel, but we generally don't have that much with our GYN. And over a course of 25 fractions, it's probably going to even out. If we do scan a lady and she's just really, really gassy, we might have her come back because, of course, whatever you use for your planning imaging is what's going to be planned on and used for even your OBI comparison. So,
Yeah, and just to add to that, I think these air bubbles move around so much, so it's really just practically difficult to account for them. Over here, we're moving towards like daily adaptive planning in some cases, and we see like when we're taking images of the patient while they're lying on the table, you see the gas bubbles just moving around while we're delivering the beam. So it's really hard to account for that if you're not making a
correct,
new plan each day, which is
correct.
sometimes
Yes,
obviously not very practical in a lot of settings.
yes.
How do you use the GEUD tool? Do you know what that is?
So I think you're referring to the EUD. What it does instead of, so in my era, we used to just put some points along the DVH line to try to gently move the DVH in the low dose, mid range, and the high dose region so that you have a gentle push of your DVH. Now, a lot of planning systems have inherent EUD where what you're doing is you can put in values and it tries to move that curve for you. I When I teach the students, I like to tell them first to put points along the DVH because you can see what it's doing and you have some control of your plan. I think everybody is moving towards so much automation and AI and what have you that you don't always understand what's integrated, what's happening inside the planning system. So this EUD is kind of replacing when we used to just put points along the curve. And it's moving it whether you want to move the mean, whether you want to use move specific percent doses, dose per volume doses, or sometimes max. So they're just different tools that you can use. I know we've started to have some lectures where they are using LET values to try to move some kinds of things. So, I mean, medicine is just evolving, and we're going to probably have more tools to help us to spare these OERs.
Maybe in 15 years, we'll be seeing biologically guided
Yes.
radiation therapy. So
Yeah.
the future is coming.
Yes.
Also another question came in that maybe I should take. What do you do when physics QA does not pass? So oftentimes that will mean that the plan might be overly modulated. So there are maybe too many small segments that are delivering kind of unstable doses of radiation. So in which case, if it really, so I guess the first step would be to start playing around with the tolerances. So maybe increase the percentage, the dose difference percentage to 4%, see if that makes it better. Increase the distance to agreement to 3 millimeters instead of 2, and start to get a sense of why it's failing. It's hard to explain, but once you start playing around with that, you kind of develop intuition in what's wrong. But in extreme cases, which I will say are quite rare, the plan is too overly modulated, and in that case, I would kick it back to be replanned in, I guess, a less aggressive way. So,
Mhm.
and you can always get a sense of how modulated a plan is if you look at the IMRT factor, which is it's basically the number of MUs divided by the dose in centigrade. So if you have IMRT factors above, let's say 4, you're starting to approach the land where maybe your plan is becoming a little bit too modulated, which in some cases it's just necessary, but that might start driving you towards poorer gamma results when you're running your QA.
Mhm. Yeah, I was going to say definitely as a planner, there's things that you automatically know. If you're having to renormalize too much, you're probably pushing an OAR much harder, and then it can't cover the target. You want to look at your OARs before you even start planning. If there is significant overlap of small bowel to your target, you might want to have that conversation with your doctor because you will not make those constraints. And if they insist that you do, your plan is just going to be extremely overmodulated. And I forgot to mention that. Look at your monitor units. You'll get a good feel for what your monitor unit values should be when you total them divided by the dose. You'll just know right off the bat as you do these, you'll know. And also make sure that you put, like I said, what we call a physics point or a DSP point in some real tissue. Because sometimes that's the first thing we'll do is we'll send it to Mobius and physics will say your gamma is way off. And it might just be that it needs another point of reference that as it's calculating and doing its comparative analysis. So those are all things as a planner that you look at before you even send it. And just be realistic. I mean, these are tools that we have, but we still have to use common sense that you want to treat the target and you can't always spare, as the guidelines say, based on the patient's anatomy. So.
Yeah, and there's a lot of questions kind of on the IMRTQA side. Maybe that's a little outside the scope, but stay tuned. I plan to have a sort of physics lecture series delving deep into the technical aspects of evaluating IMRTQA. So we'll punt that till then. Real quick, I want you to say something on your treatment planning system. So that RayStation is becoming very popular in North America and Europe, but I think its market share outside of those two places is at this point still pretty negligible. So maybe a lot of people on the line don't have experience with RayStation. So maybe you could say a little word about whether you like it relative to Eclipse or other systems,
No,
or
I came from a Pinnacle setting, and moved like in a week, like, okay, we're starting RayStation. RayStation, I would venture to say, is a combination between Eclipse and RayStation. I mean, and Pinnacle. Pinnacle, for those who remember, was a DOS system. RayStation is nice because it's Windows based. You ever get in trouble or can't figure something out, right click. And it's just like in your Microsoft or whatever, right click, it gives you a lot more things that you can choose. I think it's just like any other planning system. You know what you need to get out of it, so you learn the tools to allow it to happen. I am not as much of a Eclipse user. I got to learn it before I leave this profession. We just went straight to RAD-Station, but I remember in Eclipse having to, and it might not still be the same, so I don't want to speak out of turn, but I don't have to make too many planning PTV volumes to try to fool the dose for coverage, soup, and inf as I used to have to do for Eclipse planning. So that's one thing that I do notice. RayStation has a fusion package. It has very good algebraic where it's not so much the I used to get confused with Eclipse as to am I asking it to subtract or expand. As you saw with the when I made that ring, you're just telling it take this and expand it by this and subtract it. The Boolean functions are to me a little bit easier to use, but that's just me coming from a different product. So I think it's a well-oiled machine. I do like that it's Windows based. It's a Citrix environment, so you can use it. You can be in the south of France and be planning for someone in Alaska, and it's a Citrix environment, so that part is good.
Nice.
But I'm not a RayStation informant by any stretch. So.
Sure. And last question, maybe we have 1 minute or 2 minutes for it. What are the benefits of using a flip-flop technique versus open field?
So, like I was saying, when we first started with VMAT, we were noticing that we would do all of the objectives and we would go to hit, run, so it can start to modulate and create a fluence map and then convert it. And the MLC carriage was limited in the X direction. With GYN, a lot of times that PTV is pretty wide. And so we were finding that when it just auto expanded the field size to cover the PTV with a margin, our leaf carriage was sometimes a problem. So we started to flip-flop for the more efficient usage of the MLCs in the X direction, but we just also found it just with that little bit of overlap, that 2 centimeter overlap in between the two flip-flop arcs, just helped with the tumor coverage, but also helped to reduce some of the spare inherently before we had to start setting so many objectives. Because as you set more and more objectives, your modulation rate increases, your MUs increase, and sometimes that affects your outcome with the QA. We also do it with head and neck also, because as you know, some of those head and necks, those chains and the volumes get to be enormous, and you just can't always cover it efficiently with the MLCs in the X direction.
Right. And yeah, still more questions coming in on IMRT. So I'll just very quickly say, normally the IMRT factor 4, once you get above 4, it's becoming too modulated, but this is not like a hard and fast rule, it's more just like start to see when you're becoming too modulated. If that correlates to your gamma going down too much, then it might, but I would hesitant to say if it's above 4, kick it back to the dosimeter. It's definitely not. And also with IMRT QA, like the gamma metric, right? AAPM guidance says that if it's under 90%, it doesn't pass. But still, is that big? I don't know that that's a hard and fast rule either, right? I don't know if there's any clinical data to support that a plan with an 89% gamma is going to clinically affect the patient. But it's just something to think about and try to gain intuition and realize when the plan is too modulated, maybe this really isn't the plan that we're delivering because of the overmodulation. And yeah, with that, let's thank Kim so much. And we are going to move on to another Kim. So this one is Kim Rands. So Kim Rands is a teaching professor in the bachelor's radiation therapy program at the University of Alberta in Canada. He has over 29 years of experience in radiation therapy and medical dosimetry. He has held roles as a staff radiation therapist, medical dosimetrist, consultant application specialist, and treatment preparation manager. He served in all types of officer positions, including president of the Medical Dosimetrist Certification Board from 2004 to 2010. He's experienced in utilizing various treatment planning softwares and EMR software application. He also volunteers to promote oncology efforts in Africa with the aim to improve cancer care survival rates in patient-reported outcomes. And today, Kim will be speaking about three-dimensional prostate planning. So we're switching genders here. So moving from GYN to prostate patients. So take it away, Kim.
Okay, thank you. I'm just going to share my screen here. So I just have to allow my privacy access here for my Zoom. Sorry,
No rush.
Oh,
We were saying before the call, Zoom always decides to change its layout every single time you wanna do something.
yeah.
So okay, your screen is showing. Now your presentation is showing.
Okay. Can you see this? Can you see it now?
Yes.
Perfect. Okay. Well, thank you everyone for joining. Thank you, Jill, for the introduction, and thank you for those of you that have got up really early or into your late afternoon. I know there's people from all different time zones today, and just want to thank RAD-AID for the opportunity to present on 3D prostate presentation. So just some objectives for this talk. When I was developing this talk, I always think of target audience, and I think this type of presentation. So we've probably got people around the world treating prostate cancer using cobalt machines with Saraband all the way up to protons, and so try to fit in kind of some material that will be relevant to everyone. So I tried to pick, I try to do kind of a little bit for try to get the most target audience for the presentation. So just kind of three quick objectives, just to recognize an optimal dose distribution, to verify appropriate treatment planning techniques for prostate cancer, and then to appreciate the limitations and benefits of 3D conformal RT for prostate cancer. Okay, so I'll just go through some background. So some of this is probably a review for some of you. Some of you probably maybe don't even think about it that much. So the prostate, there's kind of four different, there's different zones kind of in the prostate. So we have kind of transitional zone, anterior zone, peripheral zone, central zone. And then you can see here, so this is kind of the anatomy of the prostate. So the prostate gland lies posterior to the pubic symphysis, anterior to the rectum, inferior to the bladder neck, and sup to the urogenital diaphragm. The urethra, of course, runs through the gland as it descends from the bladder to the urogenital diaphragm. And normal prostate gland is typically on average 20 to 30 cc's, with the peripheral zone representing 2/3 of this volume. And the majority of prostate cancer arises from the peripheral zone and is often multifocal. So you can see from this diagram here, so most benign prostatic hypertrophy, so that's BPH, rises from the transitional zone, and 75% of prostate cancer rises from the peripheral zone, which contains mostly glandular tissue. Sorry, the BPH is the transitional zone, and it's usually asymptomatic and detected because of abnormal screening on a PSA. And then you can kind of see here on this, it's a little bit squished, but you can see some of the anatomy here. So we have our seminal vesicle, we have the median lobe bladder, prostate, the pubic bone, rectum, and the penis. So just some words about for prostate cancer in terms of how the disease spreads. So it spreads through blood and lymphatic systems. It's drained by the obturator internal iliac nodes, primarily. The external presacral, presciatic are also involved, and distant mets are most commonly results in osteoblastic bone lesions in the axial skeleton. So you can kind of see here, so this is some of the previous speakers mentioned consensus contouring guidelines. So these are available, online. Just, you can just do a quick kind of Google search. So this is something that, so who's ever contouring in your clinic. So I know depending on, and that's another thing with contouring. So contouring can be done, there's some countries don't have dosimetrists, so some countries will have physicists or radiation therapists do the contouring. Some countries will have either residents or oncologists do the contouring, and also the technology in contouring as well. So we have now, we have software now that can auto contour everything you're seeing here on this slide and the next slide. So you can contour all your lymph node groups and for different various sites, and it's pretty accurate. So so if you're at a center and you don't have auto contouring software, like I said, there's and at the end of the presentation, I'll show you a couple, 2 to 3 websites that you can go to, watch some videos just for pelvic cancers and other cancers that you can go through different materials to kind of review. There's some really excellent videos on contouring, especially for pelvic tumors, and there's also technique as well, and then also based on like whether you're using Pinnacle, Eclipse, or RayStation, there's different videos on that as well. So just quickly, I'll just go through some principles of RT and prostate cancer. So the modern RT techniques. So for prostate cancer, it's one of those sites where, I mean, there's just a whole myriad of different treatment techniques that you can use. So, so there's, of course, there's surgery, there's radiation therapy, there's, active surveillance, there's brachytherapy, there's high intensity ultrasound, there's cryotherapy. I mean, there's just, the list just goes on and on for prostate cancer. So for radiation therapy, as some of you know that have been in the field for a few decades, so this kind of started with your classical borders like L5S1 on your soup and such to cover the lymph nodes. But with the advent of CT and MRI, we can do conformal treatment planning. And I think there's probably quite a few out there listening right now that you may not have access to a LINAC that can do IMRT or VMAT. So it's important. I know that in most countries, they do have access to a CT scanner. So in that case, your contouring and how you're doing your 3D conformal is quite important. Yet you may not be able to, you know, curve those isodoses how you would like with 3D conformal, but at the very least, you can you know, treat these patients correctly and help them to live a long and fulfilling life. SBRT is a newer technique with improved setup accuracy and delivers high doses of radiations up to 5 fractions. I won't be covering the SBRT today. That's kind of a whole topic in itself. I'll be concentrating more on the 3D conformal. So these advances with the use of fiducial markers, ultrasound, and cone beams. So the fiducial markers could be like gold seeds, or there's different systems like there's like the Calypso system with a kind of a radio transponder type of thing. There's cone beam CT. Typically on a semi-modern LINAC, on a conventional LINAC, you're going to be using you know, KV-KV match or a cone beam CT. On an older type LINAC with the MV imager, the gold seeds, you know, if you can, those would really help to, you know, localize your prostate. Prostate does, it does move around a little bit, and I'll go into that in a little bit. So there's some unpredictable motion and position and motion of the prostate gland, and adjacent, you know, when you compare it to the bladder and the rectum. So you have to, you do have to take this into account when you're treating your prostate cancer. So when you're, another thing for prostate cancer is your margins around your, you know, around your structures. So if you, inadequate targeting of the prostate can lead to underdosing of the tumor, inferior therapeutic outcomes, and increased toxicity. And then I'll go through some of the organs at risk and some of the constraints that are commonly used for this type of treatment for prostate cancer. So therefore, target volume delineation, tumor localization, patient immobilization, and treatment delivery must be carefully considered. In terms of the patient immobilization, so typically, you know, these patients would be supine, comfortably full bladder, empty rectum. There is some, you know, there's some centers that will do some prone technique as well, with and without a belly board. So altogether, the advancements has allowed for safe delivery of higher radiation doses, which correlate to improved PSA control, overall survival, and modest changes in toxicity and patient-reported quality of life. So just a couple quick review for staging. So this is the AJCC tumor staging for prostate cancer. So we have anything from a TX, so we have T0, T1, T1A, T1B, all the way up to T4, which is metastatic. The other kind of thing they use is the digital rectal exam. Has been previously the main tool in making this determination, but with routine PSA staging, prostate cancers are predominantly diagnosed at earlier stages. And then T1C, which represents the most common clinical stage. As such, many imaging modalities are used adjunctly to provide more accurate staging information. So just moving on to some of the imaging now. So just some kind of facts about CT. So CT does not play a role in either prostate cancer detection or primary tumor staging due to its inadequate soft tissue contrast discrimination between the prostate and the underlying LAM. It may only accurately predict tumor extent up to 65% of the time. The main role for CT is nodal and distant metastatic staging. Nodal METs occurs relatively late in prostate cancer diagnosis. And while neither CT nor standard MR is ever is able to predict microscopic nodal METs. CT may detect lymph nodes larger than 1 centimeter in diameter with a sensitivity of about 36%. And these are just based on different studies that they've done. And I have some reference slides at the end in case anyone's interested in look up some of these studies. MRI. So some of you may not have access to MR for any tumor site, but MR is it's an important complementary tool for prostate cancer. So if you do have access to an MR, the best would be if the MR is in the treatment position. If you can do that, the fusions, when you do the image registration, it just goes a little bit easier and that type of thing. So for the MR, you can use 1.5 to 3 Tesla MR scanners, which has a superior SNR ratio, which produces excellent image quality, which can be achieved even without endorectal coils. Other MR sequences can increase the predictive power of a T2 weighted image for diagnosis. And diffuse weighted imaging also can differentiate benign from malignant disease by inferring cellular density. And prostate cancer has a lower diffusion coefficient than normal prostate, and this property can aid in detecting prostate cancer. So this is kind of a typical setup for an MR. Some of you may have not seen this, so I included this slide. So this is what it would look like for, so what you need is, you want the patient to be comfortable kind of on a flat tabletop. You want them to be, in the treatment position. So you want to have your ankle and knee rest supports. And then you have your coil kind of over the patient. You have your coil holder, the anterior coil, and this all this of course is MR compatible equipment. And then this patient here, they have some earphones on to just help reduce some of the noise from the actual MR scanner. Just a quick thing on Gleason grade. So the Gleason system is based on morphologic architecture of the prostate cancer. The Gleason grade applies to adenocarcinomas only. The Gleason grading scale is from 1 to 5, and then the Gleason scores is the sum of the two most prevalent Gleason grades observed from the tissue sample. Dose and fractionation, like I said, I'll just be more concentrating on kind of conventional fractionation and not kind of some of the under 5 SBRT type regimens. So your typical fractionation, it's going to be 1.8 to 2 gray per day, with 45 to 50 gray for the pelvic lymph nodes, and then doing a cone down for the prostate, ideally 78 to 80 gray. So your dose escalation, that really depends on the technology that you're using, because yeah, you can treat to 80 gray all day long if you want, but then you're going to have increased rectal and bladder and femur head and possibly small bowel toxicities. So you do have to keep that in mind. So depending on, like I mentioned, that kind of spectrum before, if you're treating with cobalt, with Cerebin versus all the way up to multi-arc, VMAT, or even with protons, your dose escalation is really dependent on the technology that you're using. So we have a whole spectrum in between, but typically most fractionations now, at least if you can get the prostate to at least 74 gray, ideally 78 to 80, that would be good. The dose escalation has shown significant to improve the biochemical cure rates. And the rationale for IMRT versus 3D, like I explained, is to improve the conformality and to create the steep dose gradients between the PTV and the adjacent structures. So the advancements in the treatments allow for more conformal treatment of target volumes and decreased doses to the OARs. And with the advent of 3D IMRT, you can do the dose escalation without significantly increasing the acute side effects or the late complications. So this is just, this is kind of a treatment planning recommendation. This is from a textbook that I use to treat the radiation therapy students. So like I said, there's different consensus guidelines. This is one adopted from kind of UCLA. So there's group 1, group 2, group 3, group 4. So depending on the risk, so you have different PTV expansions. So group 1, so low risk. So you'd have a CTV to PTV expansion of 0.5 with your dose per fraction of 78 to 80 gray using 1.8 to 2 gray per fraction. Group 2, this would be prostate plus the proximal 1 centimeter of the seminal vesicles, same expansion, same dose. And group 3 would have the ADT for 4 to 6 months, starting 2 months before the initiation of RT. So this is based on the Gleason, the PSA, and the staging as well. So this would include the pelvic lymph nodes. So we would have CTV1, CTV2, and we'd have a 0.5 expansion on those. And then and the doses would be for the pelvic lymph nodes would be 45 to 50.4 gray using conventional fraction, and 78 to 80 gray for the prostate itself. So just some of the treatment options. External beam is the commonly utilized to treat clinically localized or locally advanced. EBRT alone may be applied to any clinical stage, T1 to T4, but is also often used with the ADT for selected higher risk patients. And EBRT is also utilized for adjuvant or salvage therapy in post-prostatectomy settings for patients with high risk clinical features with a rising PSA following radical prostatectomy. So getting into some of the techniques. So for 3D conformal, this technique usually consists of a 4-field box or bilateral 120 degree arcs, which were delineated from bony landmarks. Or, if you have, depending on what your technology is, from either a single CT slice to a full CT scan with MR. So like I said, there's kind of a range depending on your imaging technologies. With historically, these non-conformal techniques, prescription doses to the prostate were limited to 64 to 70 gray due to significant volumes of normal tissues that were in the field. And since then, we've kind of come from kind of single slice to full CT, full MR, and with the IGRT, which is the image guided radiation therapy, we've come from MV imaging to KV to cone beam as well. And then also with the advent of the newer MR Linacs, we can treat prostate cancer with real-time the MR image of the day, where we can use adaptive radiotherapy. There's a couple different workflows there, from adaptive shape to adaptive position, and where we can verify the location of the prostate in real time on a daily basis. Okay, so these are DRRs of your. So this is kind of the 4-field box technique where you can treat the prostate itself. So this would be your typical figure A would be kind of your APPA fields, and then figure B would be your lateral fields. So this would be some of your classical borders depending on what you're treating. So this one includes the prostate, seminal vesicles, and pelvic lymph nodes. So if you're at a center and this is the technique that you're using, and we've gone, some of the prior speakers went through, some of the techniques, for four-filled box. Typically, this will be higher energy, depending on what beam energy you're using, but typically, 10 to 18 MV, depending on which VMAT lender you're using. You'll be using MLC leaves, to shield, like say the femur heads on the APPA. On the laterals, you'll be shielding some small bowel, normal tissue as well. Of course, if you don't have MLC, you'll be using Cerabint. Typically on these ones, for the four-field box technique, it's your standard. You want your 95% coverage of your target volumes of your PTVs. You don't want your hotspot to be, above 110%. You also need to look at the locations of the hotspots as well. And then also the hotspots will depend on the, the lateral dimension and the APPA dimensions of the patient, of course, and then beam energy as well. You can use field and field as well on these if you have MLC to reduce your hotspots typically. This is a kind of a one slice of a isotopes curves for the two bilateral arcs of 120 each. The isodoses are tighter along the angles avoided by the arcs. So the isodoses are normalized at the isocenter. Pelvic lesions such as prostate have been popular sites for the applications of arc technique. So like I said, so depending on the age of your LINAC, if you can do arcs or not, but you can utilize this type of technique as well, which will get you a little bit more conformal than a kind of a four-field box technique. So kind of the evolution of this would be, you have your typical, 3D CRT. So you have your four-field box technique to, something like a 7-field kind of IMRT, and then kind of to VMAT, which Kristen will talk about next. So basically, with these MLC leaves, you can you can do conformal around the 3D CRT. It's a simple setup. It works well. So if you work at a center that you don't have, like, if you're still working on MV imagers, it's a great technique. That you're getting the dose in for the patient, and that that you're, obviously the rectum is going to get a bit higher dose than with an RMRT plan, because with 3D CRT we can't curve up those kind of some of those lower isodoses, like the the 70 to 90%, whereas with IMRT, we can actually curve them around the rectum as well. So obviously, some of the toxicities are going to be more for 3D CRT, but like I said, depending on where you work at, you may have a LINAC that's 15, 20 years old and only MV imaging, or you may have a modern LINAC where you can use KV or cone beam with with some adaptive planning in that case. Just quickly, I'll go through some target volume definitions. So this should be a review for most of you. So we have GTV, CTV, PTV. So GTV is the palpable or visible extent. CTV is gross tumor plus a margin for subclinical disease, and PTV is CTV plus a margin for variations in shape, size, and position relative to the treatment beam. And this is just a diagram showing, what could be, your prostate gland with a CTV. The ITV is to count for motion. There is some motion with prostate, which I'll go through that in a little bit for prostate. And then you have your PTV, and then of course you have your organs at risk. So for prostate, that typically include your bladder, rectum, penile bulb, small bowel, and femur heads. So we have here, the GTV is usually identified on DRN imaging. The CTV is the entire prostate and proximal seminal vesicles, and additional margin is added to account for variation in the daily treatment setup and the organ motion to define the PTV. So you can see here, this is your typical kind of contouring that you would find on a for a prostate case. So you can see here. So we have our GTV, CTV, PTV, rectum, and bladder, and then so the extent to define the PTV has been there's been some controversy. So in general, a PTV margin of 0.5 to 0.7 is added around the prostate and seminal vesicles to account for extracapsular microscopic tumor extension, setup variability, and tumor motion when using a daily KV or cone beam for treatment alignment. These volumes are then used for treatment planning for either 3D conformal or IMRT techniques. There are some other tools as well that you can use in terms of you have the prostate. This is on the left here. This is typically what it would look like. So if you're using a 3D conformal technique, obviously, you're going to get kind of more dose to the rectum. They have these implantable hydrogel spacers now. There's this one's Space OAR. I think there's a few vendors out there that offer these, but what this does is it offers to physically separate the prostate from the rectum. So this is kind of a big advantage, that you can get full dose to the prostate and then less rectal toxicity when treating. And this can be used with 3D conformal or IMRT techniques as well. So the daily imaging will include, like I mentioned, can include, you can use KV. Ultrasound can be used for, there's some centers that will kind of measure, that'll be used in like prostate brachytherapy, but also you can use ultrasound for bladder filling to see the number of cc's the bladder is, to make sure that it's kind of consistent from day to day as well. So these techniques fall under what is termed kind of IGRT. So IGRT is just a collective term that's used for different adaptive. And what I mean by adaptive, I'm not talking about like adaptive on the fly treatment planning. It's just more adaptive for localization. So in terms of if the patient has to be, reset up, if they're tilted or twisted, or it could be that the bladder's not full enough, that so then the patient may have to get off the table, drink some more water, and then wait a bit. So those type of things like that. So this is just an example of a post-prostatectomy using a cone beam CT with a planning CT showing analysis of repositioning. So for prostate, so if you're treating large fields versus small fields, if you have some centers, maybe they may not have the luxury of doing like a daily cone beam, so they might do like daily KV with a weekly cone beam, or some combination in between. But whatever technology that you have, for the therapist doing this, you know, it's good to make sure that you know, you have a good match each day. If you're using an MV imager, like I said, sometimes, you know, depending on the size of the patient, you know, especially on the lateral, you may not have a good image. But if you can use like the gold seed fiducials, that would be ideal, you know, for MV imaging, so you can see where the actual prostate cancer is. Prostate movement has been studied in detail. So, so depending on what papers you're looking at, the prostate can move, you know, sup, inf, anterior, posterior, you know, 1 centimeter, you know, sup, 1.25, inf, 2 centimeters, anterior, and 0.75. But the overall movement for the prostate is 0.5 centimeters, most often in the anterior and sup direction. The left-right movement is it's quite small, and then residual errors in prostate position over 7 millimeters after pre-treatment localization and adjustments clearly demonstrate the influence of the intrafraction movement of the prostate. So when the prostate is affecting kind of the CTV, a decision has to be made whether the seminal vesicles and the pelvic lymph nodes are included. So the seminal vesicles are superior and post to the prostate gland, touching to the base. So these are just some of the clinical factors when you're assessing with the stage. The Gleason score and the PSA can be related to the risk of seminal vesicle involvement, similar to the lymph node risk. The benefit of pelvic, kind of the lymph nodes is lymph node irradiation is not standard for lower favorable intermediate risk, but more, and it's is controversial for non or unfavorable intermediate to high risk. So generally, whole pelvis radiation is generally limited to T3, T4 tumors, Gleason scores of 8 to 10, lymph node involvement, and seminal vesicle invasion. Current imaging techniques, such as, you know, CT, MR, lymphangiograms, has limited accuracy for detecting pelvic lymph node mets. Therefore, improved methods for detecting lymph node mets are being developed. Clinicians are limited to using risk factor assessments and clinical judgments when determining these. The superior accuracy of the PSA and the PET. So I'll show you a slide of that in detecting pelvic nodal and distant mets over current standard of care has the potential for high impact definitive treatment planning. So you can kind of see on this slide here with the advent of the PSMA PET. So this can detect metastatic disease, and especially in the exoskeleton. So you can see kind of this patient A with bone mets, and B here. So these type of scans, you know, they may or may not be available where your center is, but with this type of imaging now, you can definitely help these patients live longer by targeting. You know, like this patient here, they have bone mets in the T10, T12 areas, so you can treat those, and, you know, give them increased quality of life for the years that they're going to live after treatment. In terms of the 3D conformal to treat lymph nodes, there is significant heterogeneity in how pelvic lymph nodes are contoured amongst experienced GU radiation oncologists. So just a note on this here, like I said, depending on who's contouring the lymph nodes, like I said, it can be anything depending on your center, but it could be your radiation therapist all the way up to your radiation oncologist. but it's important to use the consensus guidelines. There are some AI software tools now that you can use as well. Some of them come kind of right when you open up planning system, they're already there. Some of them, it's kind of a third-party system that, you know, you may have to push the scan, the CT scan to another software, but typically it's done all in the background. But you'll have, so there's a whole kind of spectrum of defining all these pelvic lymph nodes. But the software I've seen does a pretty good job now of the, you know, contouring the lymph nodes as well. And so just one thing I wanted to highlight just with the lymph nodes, the treatment of the presacral lymphatics is somewhat controversial, as these nodes are infrequently problematic clinically and are rarely an isolated site if left untreated. But typically you'll have, you know, you have your different lymph nodes that you'll contour in order to define your large fields for your prostate treatment. So this is a distribution of a kind of a salvage RT superimposed on a CT. So you can see here. So you can, you know, you can use your MLC leaves to do these, and you can get, like, I think it was Allison that mentioned that you can, or Kim, you can use, like, if you don't have, you know, if you don't have MLC, you can use your jaw as well, you know, to, you know, especially for retreatment as well. If for retreatment areas, you can use different techniques. Most of the kind of modern era, there's MLC. They may not be, you know, you may not be able to do dynamic MLC, but you can use like a field and field approach where you can do that, and you can have that as an option as well. And then these are just some of the guidelines for treating 3D pelvis prostate. So these are, like I said, these can vary. There's different guidelines depending on, like, you know, everything from, you know, Quantec to, you know, some of the different RTOG trials will have this, but typically you want 95% of your dose covering at least 95% of the PTV, and at least 99% of the GTV. You should get 100% of the prescription dose. 3D max dose, not more than 110. And then the DVH is kind of the driver of this. So this is for 3D conformal. So 60 gray should be below 50%. And then they do add one in here, 70 gray should be below 10 cc's as well. And then there's also some for the bladder. And the rectum, the femur heads should be 50 gray, cannot exceed 10%. And the mean dose to the penile bulb shouldn't exceed 52.5 gray as well. And also there's some constraints for small bowel as well. So this would be for your larger fields in terms of the V35 should be less than 180 cc's, V40, V45. So depending, for small bowel, it's kind of, it is important what you contour for the small bowel. And there's some, you know, there's some Quantec guidelines as that you can follow for that as well. Okay, and then just a couple more slides. So this is just showing some of the DVH differences between kind of a 3D and MRT. So of course, as everyone knows, you do get big, you know, similar PTV curve between the two. Probably, you know, a little bit, you know, you could do some dose escalation with kind of your VMAT IMRT, but you'll definitely get more bladder, rectal, and femur sparing, and penile bulb sparing as well with 3D conformal. In terms of, you know, for these, patients. Of course, everyone would like this, but, depending on where country you live in and what equipment you have available, you may only be able to offer your patients a 4-field box technique, but, at the end of the day, though, they're still getting treated, and hopefully, there'll be a long-term survivor for that. Okay, so at this point, I'll just show you. So these are just kind of 3 resources that you can use for the some of the resources, and I'll just pull up here really quick just to show you. So there's some of these Eclipse. These are kind of planning tutorials, and you can also switch to like Pinnacle and Eclipse, but there's lots of different links here on 3D for brain, pelvis, breast, to VMAT as well. I can put these in the chat after, these links, and then VMAT. And then there's also lots of videos as well. There's this one here, it's on YouTube. So there's lots of different videos on how to do planning with the different planning systems. So and this has a whole spectrum, like this has like 3D pelvis, 4-field, 3D or 4-field rectum. And these are quite good as well. There's quite a few videos on pretty well any tumor site that you want to actually play with. And then the Rails Contra, same with this one. They have some really good videos. Some of them are different languages, but they have some really good ones on contouring for different sites, and they just have it's just a really good resource if you're kind of, especially if you're in an area where you don't have you don't have the resources or you don't have available training. This one has contouring for pelvis, session 8 for rectal. This one here, contouring pelvis, session 5 for prostate cancer. So those are just some of the resources that you can use for that. Okay, and then just the conclusions. So like I said, prostate cancer has changed a lot over the years. There has been many advances, and like I said, depending on what country you live in, the equipment, that really depends on the type of toxicity and whether you have available for like dose escalation as well. So, and I'll kind of leave it there, and there's all my references. So is there any questions that kind of anyone has? So what I'll do is, let me go back into here and I'll stop sharing my screen. Okay, thank you very much, everyone.
Thank you so much, Kim, for that very informative lecture. We had a question come in about namely the ITV. If you could expound a little bit about what the ITV is, how it's created from the other target volumes, and also, why is it between the CTV and PTV, the CT scan in the beginning?
Okay, so typically for prostate, like I showed that slide where they've studied prostate movement. So there's kind of inter and interfraction motion. So with so for prostate, it's typically not a site where we create like a separate ITV per se, like we would like say for like a lung tumor, let's say. But so those consensus guidelines, so that they'll take into account the prostate motion. So typically, you'd have overall, there would be about, say, a 5 millimeter movement of the prostate. So typically your margins between your CTV and your PTV, so that you're taking into account that motion. So CTV plus your ITV will equal your PTV. So you're taking that into account because it is, like I said, it is a It is an organ that moves depending on rectal filling, bladder filling, position of treatment. So that's something you will take into account. So depending on what type of IGRT you're using, obviously, if you're just using four-field box technique with MV imaging, you won't be able to get as conformal as if you're using, a 2-arc VMAT with daily cone beam, or on an MR Linac where you actually can see everything moving in real time. So like I said, there's a whole spectrum of what you're actually going to do depending on the equipment that's available to you.
Yeah, I don't see any other questions.
Oh.
Yes, Adrian, do you have a question, or perhaps not? I will say that they are, so you spoke a lot about MRI in the beginning. I know that while a lot of these places don't currently have MRI, they're putting a lot of resources into sort of increasing access to MRI all over the world. I know the Gates Foundation has made that quite a priority. PET might always remain challenging due to the logistics of getting sort of radioactive material with a half-life on the order of 2 hours to places that don't have the ability to produce it. But I think MRI will be coming soon near you. Another question just came in on the use of hydrogel. So how will it affect the setup and treatment? And how long does the hydrogel stay there between the rectum and the prostate? That it should be injected a few weeks before SIM.
Truth be told, I'm not an ex, like the center, our center that one of our centers does use it. I don't know the specifics of some of the the actual hydrogel, but I do know from a dosimetric point of view, it does reduce rectal toxicity. In terms of the actual logistics of the hydrogel, I wouldn't be able to answer that unless someone else on the panel has had experience with that.
Yeah, I think don't quote me, but I believe it stays in the patient on the order of months. So a few months it will be there, which is good because that's typically the duration of a prostate treatment course. I know that we typically will inject for the patients that need the hydrogel, we'll inject it around a week before SIM. So usually they come in for the fiducial placement and the hydrogel placement. Usually that's done in the same procedure, guided with the use of transrectal ultrasound. So it's something that either a urologist or radiation oncologist can perform. Usually the physicist role, since there are many physicists on this call, are just maybe helping out with imaging. So if you guys have transrectal ultrasound imaging, you could help out there. But yeah, I think on the order of a few months is how long it will stay there. And yeah, like Kim said, it's very benefiting from a dosimetric standpoint because it really increases the space between the prostate and the rectum. So you place it right in that space between the prostate and the rectum. And yeah, right, it really depends on the patient's anatomy, right? Some patients have naturally a lot of space between the prostate and rectum, and some really have none. So the ones that really have none are the ones that we'll typically use with this rectal spacing.
Okay, and I've put in the chat those links that I showed at the end. So if anyone's interested in accessing some of those videos or some of the tutorials, I've posted them in the chat for you, whoever wants to look at them. And thank you. So thank you very much, everyone. It was thank you for the opportunity, and thank you everyone for listening.
Yeah, thank you so much, Kim. That was an excellent lecture. So we're going to move on to the final lecture today. This one is by Kirsten Hart. She is a certified medical dosimetrist. She has a BS in radiation therapy. She's been working in the radiation therapy field for the past 15 years, starting as a therapist and then quickly transitioning to dosimetry. She's passionate about staying on top of new treatment planning techniques and sharing knowledge. In her free time, she enjoys being outside in the mountains and spending time with her energetic children. And yeah, so today Kirsten will be talking about IMRT VMAT planning of prostate. So Kirsten,
All
I give
right.
you the mic.
All right. Hi, everybody. I'm excited to be here today. Thanks for staying on and listening to me. I'm going to start sharing my screen. And we'll start with the slideshow. Can you see this?
Yes.
Perfect. All right. So
Beautiful
quickly,
view, by the way.
yeah, so I get to see this view in a couple weeks. The colors of the trees will start changing, and this is about 20 minutes from where I live. So I just wanted to start with kind of where I'm at in the country. So yeah, I'm going to be talking about prostate, IMRT, and VMAT. Thanks for everybody before me for setting me up and going into the nitty-gritty of contours and dose constraints. I'll go over some of that. So again, we're similar. We pretty much treat everybody supine. And I have just a brief picture of a positioning device that can be used. We prefer legs straight and some sort of device holding their legs in position. If somebody has a sore back, we will add in a knee support. But the biggest thing is trying to keep the pelvic tilt the same and the legs in a similar position. So one thing I have worked with in previous years is a block between the feet with either tape or Velcro holding that in the same position. And then as other people have talked about, we use a full bladder and a empty rectum, which is ideal for planning and treatment. The full bladder in a lot of cases can help push the bowel out of the way. And then having an empty rectum is just more ideal for reproducibility. So our contours are small bowel, large bowel, sigmoid colon, bladder, rectum, penile bulb, and femoral heads. And then the treating volumes are the prostate, seminal vesicles, and plus or minus the pelvic lymph nodes. And we use the T2 MR weight and a PET scan for all of the target delineation. So I briefly went over our contour expansions. So PTV pelvic LN is 7 millimeters away from the CTV of the pelvic lymph nodes that's drawn by the physician. Our PTV prostate is half a cm anterior, sup, inf, left, and right. And then we do a 0.3 to 0.4 cm posterior expansion. If it's SBRT, we're doing 0.3 because we make our patients do a daily enema if it's an SBRT treatment. The seminal vesicles also get the same expansion as the PTV prostate. And then when I'm planning, the PTV pelvis includes the PTV pelvic lymph nodes plus the prostate PTV and the seminal vesicle PTV. So for us, this is what we typically do. We're moving more and more away from the conventional 39 fractions, where most of our patients would get a 50 gray treatment to the pelvis and then a sequential boost to the prostate and seminal vesicles to a total of 78 gray. We're doing more and more hyperfractionated SIB plans, and where we are treating them in 28 fractions and taking the pelvis to 50/40 and 1.8 centigrade or 1.8 gray per fraction. And the PTV pelvis and PTV SVs are getting 70 gray and 250 centigrade per fractions. We also will treat the prostate and seminal vesicles only, also in a hyperfractionated at 28 times 250 centigrade. And then SBRT and seminal vesicles would be 5 fractions times 800 centigrade to a total of 4,000 centigrade. So a lot of times the patients will decide to go a little bit longer, even if we're treating this prostate and seminal vesicles, because our physician believes that erectile dysfunction is preserved a little bit better with a hypofractionated 28 fraction versus this SBRT dose. And I'm going to touch on the SpaceOAR also. So this is the Space OAR hydrogel, just like Kim Rands just posted. Our center, we use, depending on the urologist, either the Space OAR View, which has the contrast in it, which you can see on this picture over here, or Barrigel. Barrigel does not have contrast at this time, so you have to have a post-fiducial and post Barrigel MRI to be able to see it. It's otherwise really difficult. So this is an actual patient of ours that we're treating right now. And then the urologist also puts 3 to 4 fiducial markers in for easy localization daily. So for me, isocenter placement, I try to keep my therapist in mind back from when I was doing it. And I try to keep the same isocenter between boosts if we're doing a sequential boost. So for that, I keep the isocenter just above the prostate PTV, and just so we're still using the majority of the small leaves inferiorly, but then when you go to the cone down, but you're still getting the pelvic lymph nodes covered well. And if it's the prostate and seminal vesicles only, then it's the middle of the PTV. And we rarely have collision issues with that. So here is my typical beam arrangement for VMAT. I typically do 2 to 3 full VMAT arcs. It depends on what somebody's bowels are doing, if I'll add the 3rd arc in if it's necessary. And typically I'm planning with 10x, but it is okay to plan with 6x if that's what you have. And then for the prostate SBRTs, typically I'm using 10 FFF2. So I start my arcs 10 or 5 degrees off on the start and end 5 degrees off of 180. For me, I think that it's helpful for helping to spare the rectum. The other thing of note is that I really limit the X jaws to 15 centimeters just to help with the leaf travel and not so that the leaves can always close in the middle. And I just threw in a quick plan of a IMRT prostate and nodes. This is not a great dose distribution, but just to kind of give you a visual of what it is. So this is 7 to 9 beams. This one in 7 beams. I have, again, starting at 185 posteriorly, going around to help with the rectum. And then where we're located, a lot of my patients have metal hip implants, and because they're very active and have had some sort of issue. And so this causes me a lot of problems. This one is a bilateral hip replacement. So we don't like to go through the metal. So there's a couple of ways to do that, to achieve not treating through the metal. With Eclipse, there are skip arcs and avoidances within the optimizer. So this is quickly just a skip arc setup, and it's in the treatment plan parameters when you're in the optimization window. So you can tell it, I don't want to treat through this certain arc range, and that would be the entrance and the exit of this hip here and this hip here. And so you have to tell it you want it to treat from here to here, and then not treat from here to here, and then treat all the way around, and then not treat again from here to here. And then you do the opposite going back. So I see typically that the rectum and the bladder doses go up more than if we didn't have to avoid the metal implants. And that's just because you're eliminating this part of the treatment area, or the beam area is coming in. And so you'll get more spiking down in here of the lower and higher doses. And then you can get there, but oops, sorry. The 50% isodose line doesn't usually curve as well around the rectum either. So another way to do that in Eclipse is there's a way to say don't enter into the contour, so you contour out the metal hips and you put a constraint on, a low dose constraint on it, and tell it not to enter into that contour. I personally feel like I don't get as great of plans on that, but I'm sure other people do. All right, and here are some objectives and planning structures. I know Kim talked about using rings, and so I do the same thing. I have a prescription ring, and whenever I'm using rings, I prefer to put a Z in front of them, and they go to the bottom of the list, and then I'm not really ever evaluating them in a DVH, so that's why I like to do that. It's also conforming to the TG 263 naming conventions. So my ring RX is 0.3 centimeters away from the PTV and 1 centimeter thick. And then I put a max dose of 95% of the prescription. You could push that down. There's a rule of thumb that we use that's 3 to 4% fall off of the dose per 1 millimeter. And then I have a Z ring low, which is 2 cms away from the PTV and 2 to 3 centimeters thick, with a max of about 55% of the RX, and a few objectives pushing on lower doses. So I also think it's important to use dose constraints from your facility as a starting point, but so that's what I will put in as my objectives to start. But a lot of times you can do better than what your constraints are that are given to you. So I just did a couple of screenshots of an SIB prostate with lymph nodes of the dose constraints that we use. This is RAD formation clear check template. And again, as other people have stated, these are ours specifically, but they're based off of RTOGs and Timmerman and a bunch of great resources. So here are our dose constraints for a prostate SBRT. You'll notice that there are some small bowel dose constraints, but not as many, because usually, unless the small bowel is falling inferiorly, you're not having to contend with that being in the way. So, can you do better? Just because you meet the constraints doesn't mean it's the best plan that you can create. Push your objectives as much as you can before losing coverage. So, these little carrots here are what I would need to put in to meet the constraints of our goals. per patient. But as you can see, I was able to push even better than that. So these would be my starting, and this is what I was able to achieve in this patient. So this teal here is the small bowel, and the brown is the rectum. So here are rectal goals here, and this is where I'm able to get the rectum, and then the bladder also I'm able to get all the way down here. And then these are my 3 different dose levels. So in this patient, we did have a PET positive lymph node that needed to go to a higher dose, and we took that to 60 gray over the 28 fractions. And then again, just because you meet your dose constraints doesn't mean that the plan is beautiful. So you want to see the rectal, like the 50% isodose line curving around the rectum. You'll see in this case, it's easy because one, the patient has natural spacing between his prostate and his rectum, but then he also has the space OAR in there. And so it's really easy to curve the 50% isodose line away from the rectum. But if this wasn't the case, ideally you would want to have the 50% isodose line at least 50% of the way posterior of the rectum. So I'm looking at that in the axial view as well as the sagittal view. The sagittal view, you can appreciate a little bit more of the 50% line in the bladder as well. And here I'm just also showing a full bladder, what it can do to the small bowel, pushing it way away from our treatment field. And this was short, but I'm open to questions. If you need anything, please, if you have any questions, please feel free to ask.
Thank you very much, Kirsten. Short is good because we were over time, so we were able to get back on time. So what's the ideal distance from of the low dose bath from the PTV? Like a 50% line, let's say.
Yeah, that's hard because let me just go back to, of course I closed that. So just a second. It's going to spill out in different areas because you're pushing on a couple of different regions. So let me just a second here. Let me go back. Oops. All right, screen share again. Okay, so you can see that it's going further out this way. I don't have a good rule of thumb for this, but then it's tighter around the rectum. It kind of depends on what else you're pushing on. So I'm pushing on the rectum, the bladder, and the femoral heads. And so you're going to get more 50% out on in between those, and you can get it tighter. So again, going back to one of the rules I said is typically you can expect a 2 or a 3 to 4% drop off per 1 millimeter. And so if you calculate that out, you can get the distance, an idea of a distance from the 50% isodose line. That helps.
Yeah, I have a quick question. What would you say are kind of the different ways you approach planning when you have conventional fractionation prescription for prostate versus like a mildly hypofractionated case to an SBRT case?
Sure. So sequentially, everything is, I'll just take the PTV prostate or PTV pelvis, and it will have its own prescription ring and its own low dose ring. And I just make that as conformal as possible. You can take your overall dose constraints and take a percentage of whatever your PTV prostate is over the PTV pelvis, so 50 over 78, whatever that percentage is, and get a starting point for your dose, your overall dose constraint. So if you can meet those in the initial plan, then when you're adding in the prostate, you can usually get that too. So it's like the remainder of the of that percentage. So then same thing with the prostate, and then you add them together, and then you can futz with, well, I'm over on this. The majority of my plan is coming from the pelvis. Let me start from the pelvis first and try and crunch down on some of my overall dose constraints. For the SIB, one of the things I do is create a planning PTV pelvis, and that is for our case, it's the prostate PTV expanded by 7 millimeters, and then I take that out of the PTV pelvis, and that's allowing for, because you're going to get the dose automatically from the PTV prostate going into your PTV pelvis, and so it allows to control the 105 in the max dose in the rest of the PTV pelvis where you don't want the hot spots. So one of my slides had an SIB constraint, and we're looking at the PTV pelvis minus the PTV prostate expanded by 7, the amount of 105 in there, and we like to keep, so the amount of 105 of the 5,040 centigrade, which is the prescription of the pelvis, and so we want to keep that amount under 15% ideally. So, and in Eclipse, I don't use this as much, but there is a way to crop the structures out from each other. It's in the optimizer, so you don't have to do the planning PTVs like I did. And then for the SBRT prostate, I typically do create my RX ring. I'm pushing to like 90% of the prescription, so really help tighten up the conformality of the prescription to the PTV prostate. And then I'm pushing on the low dose ring also to push in the 50% isodose lines as tight as possible. And then we don't, with the SBRT prostate, we are still doing a homogeneous plan. And so it's not like an SBRT lung or a brain SRS where you want a really hot center. You want it to be more homogeneous. So we're still looking at under 107 max point.
And a question that came in the chat, firstly complimenting the VMAT treatment plan that you made, and then how did you get 90.4 low dose covering in general?
I'm sorry, what was the last part of that?
How did you get, maybe Yuri, you can specify exactly what you mean, but they're asking about your low dose covering.
So I think that the question is, so that was one of my SIB plans that I showed. And so what I do again is that PTV pelvis minus the expansion of the PTV prostate. And so that has its own objective set. And so the way I plan, and everybody's putting objectives in, is so much an art and specific to how they like to plan. So it's hard for me to tell you exactly what to do, but I always do 2 minimums. So I put in that 100% of the PTV needs to be covered by the prescription, and then 100% of the PTV also needs to be covered by the prescription plus I don't have like a great rule of thumb, but like 10 or 20 centigrade more than what the prescription is to really push the coverage of that. And then it also, those planning PTVs also have a max dose and a max 105% objectives. And so sometimes you're fighting the coverage on that, and you'll just have to weight your objective higher. So there's a couple of ways to do that, either weighting your objective higher. So if you're putting everything at 100, putting that at like 200 as a just reference, or you can also add your minimum to, like, let's say the prescription is 50-40. I'm going to put it at the minimum I want is 50-60, and then that will cover that. I'm hoping that that's what you're asking.
Yep, we had one more question come in. When you're planning VMAT, does the direction or region from where you push the dose to the PTV matter? And is it okay if it's pushed into the PTV equally from all directions?
Yeah, so VMAT is, I think, kind of automatically doing that because it's rotating around, so it takes that into account. And when you're doing IMRT, you can play with your beam angles a little bit more. And one thing I didn't go over much in the IMRT is that you can choose to not have your beams open for every field for the IMRT, to covering the whole PTV all the way throughout. So let's say you want to decrease the bowel dose, but still cover the PTV on a couple of your anterior ones. You can close down the anterior beam and just treat the posterior part because it will get dose from other of the beams.
Yeah, thank you. And what is the typical ratio of MU versus prescription that you normally achieve in your prostate planning?
Good question. So typically I'm in the 2.9 to 3.5 ratio. It does go up some when I have those bilateral hips and I have to avoid going through those, especially there's just a lot more going on. And that's when I add in a third beam also, or we'll do the flip-flop technique like Kim talked about earlier. So that's going into more 4.5. My physicist starts getting a little anxious when it's above 4.5.
As a physicist, I concur. Nice. Yeah, I don't see any other questions. I guess, would you allow all 100 of us to come over in 2 weeks to the beautiful scenery that you showed in the beginning of the lecture? That's the most important
Absolutely.
question.
If you
Nice,
can get
nice,
here, we can go on a tour.
nice. Great. Yeah, so I guess I wanted to firstly thank Kirsten for that lecture, but then thank all of the four speakers, the Allison, Kirsten, and the two Kims. This was an excellent workshop. I'm sure the people that attended got a lot out of this, especially given that GYN and prostate are two extremely common cancers that are seen in much of the world. So this is definitely a big chunk of the planners' jobs in many countries here as well. Yeah, Alicia, do you want to say a little something about the certificate?
Sure. So I am the certificate manager. So I have to essentially make all of the certificates. And once we get the list of those that attended, I will start that process and they are emailed. And we will also email out a link that includes the link to the workshop itself so that you can go back and watch the workshop itself. So, give me a couple weeks to get all that done. So, but if you have any questions, feel free to email me. My email is the letter A, WHITE, White, at radaid.org, and that's rad-aid.org. So, but we will be getting those certificates out. Hopefully, everything should be finished in the next couple weeks, no later than the end of September.
It's manual labor, so
It is manual labor
so
because I
give
have to
Alicia
put
some time
everyone's
here.
name. I have to put everyone's name and email them individually. So it is manual labor.
That's a lot of work. Sure. Cool. Well, thank you so much, everyone that spoke and everyone that attended. We will, I guess, keep your eyes peeled for future workshops. So I know we've done a general one, a breast one, and now a pelvis one. Alicia, do you want to comment on what you're thinking? Maybe the next one will be in some months.
Well, I guess if we had to tackle something, it might be head and neck. Head and
Hey,
neck or
ooh.
lung.
Right. Okay. So yeah, guys, just keep your eyes peeled on LinkedIn and emails and however you ended up finding this one. Keep your eyes peeled there because you'll probably find the next one in a few months. So yeah, with that, I will sort of officially close the workshop and yeah, thank you guys again for attending and we look forward to seeing you in the future.